Okay, so my clock reads 7 o'clock, so we'll get going just to be respectful of everybody's time today. So welcome everybody. This is the third of a series of 3 webinars that we have been given over the past few months on setting realistic expectations in the GI suite. So if you were with us for the first and/or second webinars in this 3-part series, you would have heard us discussing a variety of topics, and some of those included the differences between contamination and infection, possible sources of endoscope contamination and infection, and also talking a lot about, especially in the last webinar, education and training of endoscope reprocessing technicians. So in this final webinar, we are going to take a much more detailed look at several topics that are specifically related to sampling and culturing of duodenoscopes. And before we get started, I do have to read this disclaimer to you in full, so please bear with me. The comparison to competition that has been written to the best of our knowledge at the date of publication. Please keep in mind that our competitors enhance their products as well, so their products may have changed. Make sure you use competitor comparisons carefully in your conversations. This material does not constitute medical or legal advice and should not be relied upon as such. This material should not be considered as a substitute for carefully reading all applicable labeling, including the IFUs supplied with the devices, and publish peer-reviewed articles concerning the topics presented. Before using any product, please thoroughly review the relevant user manuals for instructions, warnings, and cautions. The techniques, instruments, and settings can vary from facility to facility, and it is the clinician's decision and responsibility to decide in each clinical situation which mode and settings they use. All right, so I will be your moderator once again for this final webinar in our series. And my name is Melinda Benedict. I am the current Global Senior Manager of Infection Prevention at Olympus. And I am very happy to share that we have both of our panelists from both the first and second webinars in the series returning to close it out with this final event. And I'll introduce them now. Dr. Michelle Alpha is a clinical microbiologist and world-renowned expert in the science involved in endoscope reprocessing and hospital-acquired infections. She has over 30 years of experience and over 150 publications to her name. Dr. Alpha's research has provided invaluable contributions to the understanding of such topics as biofilm, the importance of monitoring manual cleaning effectiveness, and endoscope culturing. So thank you again for joining us, Dr. Alpha. Our second panelist is Dr. Gregory Cote. Dr. Cote is a gastroenterologist currently practicing at the Medical University of South Carolina, where he focuses on the diagnosis and treatment of acute and chronic pancreatitis, gallstone disease, and other disorders of the biliary tree. Dr. Cote is also the principal investigator for several federally funded clinical trials. Welcome again, Dr. Cote. All right, and as I mentioned a few minutes ago, the main focus of tonight's webinar is the sampling and culturing of duodenoscopes, and specifically really getting into more of the differences between what is a low concern organism and what is a high concern organism, and also how to interpret the laboratory results that are obtained through scope sampling. In my current role here at Olympus, I do notice that there is quite a bit of confusion surrounding these topics, and understandably, there seems to be a bigger learning curve associated with understanding the actual laboratory reports than there is for the actual physical taking of the sample from the endoscope. So I hope that by kind of focusing on these aspects of sampling and culturing, we can address some common questions and concerns that you might have today. Just to let everybody know, if you think of any questions during the course of this presentation, there is a chat function or a chat box. You can feel free to type them in there at any time. I have a few colleagues that will be monitoring the chat and either answering the questions or sending them over to me to hopefully address at the end of the webinar. We will get to as many questions as possible until our time is up for tonight's presentation. So with that, let's talk about low versus high concern organisms and interpreting lab results. So jumping right in with the first question or set of questions for our panelists. Is sampling and culturing a requirement for any healthcare facility? And are there alternatives to sampling and culturing? So I think Dr. Alpha, we'll start with you for this one.
Okay, and Mindy, if you can go to the next slide, I just want people to remember that the Duodenoscope surveillance sampling and culture protocol that was prepared by the panel and it has been approved by the FDA, the CDC, and ASM is actually the only culture method for duodenoscopes that's actually been validated by the manufacturers and has been shown to provide 65 to 100% extraction efficacy. I think it's important to remember that if you're going to culture, remember that the FDA, CDC, ASM protocol, it is not a requirement of them for sites to do culture of their duodenoscopes. It's left up to the individual facilities. But I think it's important to know that if you do decide to culture and you're using this protocol, it's important, and it actually states it in the protocol, that the expectation is that the instructions will be followed to the letter and that there won't be changes to the protocol because the validation done by the manufacturers was done following the instructions step by step. So in terms of culture, the question, one part of the question that you asked is, what are the alternatives? And there have been a number of alternatives that have been suggested, some of which may be potentially utilized, and there's others that probably will not be at this time acceptable alternatives. One that has been bandied about is the use of the rapid ATP tests. And there is a sense that this is a rapid test, that if it were able to detect very low organisms or very low levels of organisms, it would be a great silver bullet to answer our question when we start an endoscopy procedure as to whether or not that scope is safe to use because it's not contaminated with organisms. And I think it's important that people realize that ATP testing is not designed to detect low levels of organisms. And at this point, it definitely is not a substitute for culture. And in fact, there is a section in the FDA protocol that actually addresses this particular component. And the reason for that is that it does not detect low levels of organisms. You need about 1,000 colony forming units for it to give one relative light unit. And, you know, that's just not sensitive enough at this point in time. The other couple of tests that are out there that are not addressed in the FDA protocol are, there is an overnight rapid gram-negative test that is commercially available, and it can detect low levels of the gram-negative organisms, but keep in mind that the action items that are given in the FDA protocol are based on the detection of all high concern organisms. And yes, the gram-negative bacilli are probably the ones most involved with outbreaks, but there are other high concern organisms that are gram-positive that would not be detected by the rapid gram-negative test, obviously. And the other thing is that CFU, high CFUs in the FDA protocol is a concern and it's considered actionable, but these would not be detected by the rapid overnight gram-negative culture method either. And finally, PCR, or polymerase chain reaction testing, that amplifies the genetic material. It's been shown to be feasible potentially as a method of detecting organisms present, but currently it really hasn't been applied and used on a main basis. So I think it's important to realize that if you're doing culture, the only validated culture methodology is actually the FDA, CDC, ASM duodenoscope protocol that's shown on this screen.
Great. And Dr. Cote, you know, we just heard from Dr. Alpha that this is a validated protocol, but from your point of view and in your knowledge, is there any data that exists on the impact of endoscope culturing and how that may reduce clinical infections?
There are not. So I think this is really the conundrum that clinical practices are facing and hospitals are facing, is that, as Michelle said, there's really no surrogate for the culturing process to detect organisms on a scope after it has been disinfected. And so really, as I see it, a culturing program in your facility is really a quality check on your process so that you can confirm that you're doing a good job reprocessing your equipment. Realistically, in order for a culturing program to reduce the risk of a duodenoscope or any endoscope associated infection, you would have to culture every scope after every use to confirm that it is not contaminated with a high-risk organism, and therefore, safe to use on the next patient. And that's just completely impractical. And again, to get at sort of the root of we discussed, I think, during the first of these three webinars, is that the relative risk here is so exceedingly low to show any meaningful reduction in duodenoscope or endoscope associated contamination of a subsequent patient or infection of a subsequent patient would be extremely challenging. So I think this is the balance that the FDA and other regulatory bodies have had to face. They are providing us with a very thoughtful process to culture your equipment. And I think it is a good idea to be familiar with this and to do it in your unit intermittently, again, as a quality check, really on your process, on your processes, as well as on your technicians, on your team. But to have this be a regular part of your program on a weekly basis is, at this point, impractical. Hopefully, we will find that something like ATP testing or one of these other newer rapid tests that Michelle mentioned will be recognized as a surrogate, as an equivalent to a full-blown culture process. And then at that point, you could imagine it would be more practical to apply it, again, still as a quality check on your reprocessing program. But bottom line is the baseline risk remains quite low, number one. Number two, culturing needs to be done. Really, it's the only way to test your process, and it is time consuming. It's not only labor intensive in terms of the personnel, but equipment intensive, because the components need to be taken out of circulation while you're waiting for the results for it to really make a difference. And I think we'll rehash this later on this evening. And so as a result of that, it is not a requirement by the FDA. It's a recommendation to consider.
Great. I think we'll move on. Oh, Michelle, did you have something to add to that?
Yeah, I was just going to add one last comment is, everything that Gregory said makes total sense. Keep in mind, though, that even the FDA, I think, was surprised when they did the 522 post-market surveillance clinical assessment of the extent of endoscope or duodenoscope contamination. And they themselves reported that there was 5.4% of all of the duodenoscopes that were cultured from many different endoscopy clinics in the US that had high concern organisms, and that 3.6% had low to moderate concern organisms in what would be levels that were unacceptable. So I think as you're contemplating, and I think all the points that we've made clearly spell out the pros and cons of what culture can and can't do for you, I think keep in mind that there are a lot of centers that probably don't realize whether or not they have any contamination in their scopes. And as a periodic process and part of a quality insurance or quality assurance program, I think it is good to at least have some idea of whether you do have endoscope contamination going on or not. And the frequency with which that can be done, I think, is something that has to be thoroughly considered before starting actually doing it on a more regular basis.
Okay. Great. So moving on to the next slide, and Dr. Alpha, I think this one's yours, but I think it's a great idea, and this is a really good visual for those attendees who have never either done an endoscope sampling or seen it done or had a chance to look at that FDA protocol, to kind of give them a very high level overview of how to actually get a sample from a scope. So if you could walk us through this, I think that would be very useful.
Sure. This image was taken directly from the protocol, so acknowledgement to the FDA CDC ASM protocol. Essentially, the sample collection is a single sample, and it was designed to try to take into consideration making it easy for people to be able to sample the instrument channel. So it's a sample that is assessing the biopsy port shown by the blue arrow, all the way down to the distal end and the elevator recess cavity as well, because obviously that's a very complex component of a duodenoscope and one that has been thought to be one of the reasons why there can be so much contamination. Now, it depends on your duodenoscope model. If you have one that has an unsealed elevator guide wire, a sample would also be taken from that unsealed elevator guide wire, and that's again shown there on the left side from the elevator wire port down to the distal end. And all the components taken from these various places would be pooled into one sample so that you're assessing those components of the duodenoscope. The key components in this, and forgive me as a microbiologist because I'm very anal retentive about the details sometimes, but I think it is important because you may read in the literature where individuals have done cultures on their duodenoscopes and have zero contamination. But if you look at the materials and methods and you compare them, the key components for this FDA CDC ASM protocol are that sterile water is used for the flush, primarily to make sure that no extraneous components like proteinaceous material are introduced into the endoscope during sample collection. And the fact that a bristle brush is passed down the channel, and it's also used in the elevator recess to provide friction to ensure optimal sample recovery. So in both the instrument channel and the elevator recess, it's a flush, brush, flush approach that's taken. The objective being to try to extract the most material as is possible. And the other key thing that is often missing in many of the other studies that have been published in the past years has been the neutralizer being added to the sample. So the FDA CDC ASM protocol, when the sample is collected, an equal volume of neutralizer is added to protect the organisms, to ensure there's no further damage, and to neutralize any residual traces of the disinfectant that might be present. So these are the key components, and when you're looking at published information, I think it's really important to look at the methods to see how sensitive their protocol was and compare it to the FDA CDC ASM protocol because the key components are the ones I've listed here. And if we can maybe go, do you want to go to the next slide?
Yeah, let's go ahead and do that.
Okay, so once the sample is taken and is transported on ice to the laboratory, you may be using a private lab or you may be using the clinical microbiology lab in your healthcare facility. It is important that during transit, the sample is held on ice, especially if it's going to be sent to an external private lab where it might take 18 hours of transport time. Now, in terms of what the lab does with this, this is one of the key parts of the protocol. What we want to do is get the most sensitive culture protocol. And if you look at some of the published data in the past, a sample might have been taken, and it might have been 20 or 40 mils of sample, but only 0.1 mil was actually plated onto the blood agar plate. That's a very small fraction of the entire sample. The key component of the FDA CDC ASM protocol is concentration of the entire sample. And the preferred method is by filtration, so that the whole sample is filtered through a membrane, and that membrane that will then retain all of the organisms in the sample is transferred to a blood agar plate for this protocol. So if you look at the picture in the diagram, that's what the double asterisk is about. It's showing you a picture of a membrane filter. That white circular material there is a membrane filter that's had a sample pass through it. And each organism, each bacterium that is captured on that filter, once that filter is placed on a blood agar plate, as shown in the diagram, and incubated, the colonies will grow, or the organisms will replicate and form a colony. So a colony forming unit means there's one organism that replicated and we can detect it because it's grown enough to form a colony. The incubation time that was selected, and this was very controversial because, the longer you incubate, the more things that can grow. But from a practical point of view, you want to get the results back to the endoscopist as quickly as possible. We settled on incubation for 72 hours with a preliminary negative report. If there was nothing seen at 48 hours, a preliminary would be sent out, much like for a blood culture report, where, preliminary interim reports are sent out so that the physician knows what's going on. And the focus is really on high concern organisms. those that have been associated with outbreaks, or where there's many colony forming units. So if there's more than 100 colony forming units, this membrane would be almost chock-a-block full of organisms. And that's an indication that something has gone wrong and would be considered unacceptable. So that's the process of collecting a sample and culturing it. Both the sample collection is important and needs to be done correctly and optimally, and the culture needs to be done in a way that makes it the most sensitive culture method that's possible.
All right, great. And I think, Dr. Cote, from a clinician's point of view, can you walk us through sort of some of the logistics at a facility level and some of the topics I'm thinking might be useful for attendees to understand more about is, sample timing. When would you take a sample from a scope? How does that timing impact procedure workflow? And who takes the sample? Who are the people doing this?
Right. So this is, as Michelle said, that the technique of simply getting the sample is sophisticated. And so to ask our nurses and technicians to all be universally comfortable with this is, I think, unreasonable. So obviously, as part of your program, there needs to be individuals who are identified that are responsible for obtaining these cultures. We've had in our unit, we typically will have individuals from our infection control team, so they have nothing to do with our endoscopy unit, that come and obtain these samples. Now, they're not familiar with the equipment, so then you still need your technicians there in our reprocessing suite, to help them just with the sort of scope handling and so on. But the actual process that Michelle described would be actually obtained by someone who's trained specifically in procuring these samples. So the other sort of challenges is when do you do them? So the ideal time, theoretically, you do this every Friday so that the samples can cook over the weekend when you're doing fewer procedures, and then you'll have your preliminary results on Monday, and you can bring the endoscopes back into circulation. But it's a bit of a flawed approach, because let's say you have your best technician, your most experienced technicians reprocessing scopes on Fridays. Well, you may have falsely low rates of contamination. You may have a skewed sample. So I think personally, if you really want to make a commitment to this, it really should be a true random sample intermittently throughout the week, different times of the week, and then we'll talk about how to handle the duodenoscope or the endoscope, any other endoscope that you're culturing during the process of waiting for results. But ideally, it's done at random times of the week, so that you have a true, again, quality assessment, quality assurance program on your reprocessing program.
Okay, great. Thank you for that. So I think moving on to the next set of questions, we just talked about duodenoscope sampling and culturing at a mid to high level. So now I think we can kind of dive a little bit more deeper into the details and maybe more of the logistical concerns with this. And I think, as everybody looks at these next two questions we're going to deal with, maybe it's a good idea to think about what would happen if maybe a high concern organism or a multi-drug resistant organism would be found in a sample taken from a particular scope, and how that might affect if and how a facility might decide to quarantine their sampled scope. So once the sample is collected from the endoscope, what should the facility do with that scope while they wait for the lab results to come in? Should they quarantine the scope, or can they continue using it on patients? And Dr. Alpha, we'll keep this pattern up. We'll start with you on that one.
Yeah, this is one of the toughies. It's very interesting because the FDA protocol doesn't actually comment on this, because there was a lot of discussion about it. Obviously, it's ideal if the scope was quarantined, the way Dr. Cote had mentioned, and I think that should be the objective. And in order to, how will I put it, accommodate quarantining an endoscope, if you take a sample from it and quarantining it, one way is the sequence that Gregory mentioned, which is taking the samples on Friday and you get some of your results back on Monday, and then there's a over the weekend kind of period. The other alternative is making sure that you have sufficient inventory of duodenoscopes to allow you to actually quarantine your scope during the time frame in which a scope is being cultured. And that might require 1 or 2 additional scopes, depending on how many you have in your inventory and how many you plan on culturing at any given time. I think that the sad thing about the reality of medicine is whenever you get more scopes in inventory, it tends to mean there's a tendency to want to, schedule more of the procedures, and you still have the same dilemma that if you quarantine the scope, it still impacts on the number of patients that can be seen, and that's true. So I think serious consideration has to be given to, if you are going to sample, I think I would say recommend that quarantining be done, especially if you are starting culture and you really don't know what level of contamination you may or may not have, and keeping in mind that it's not specified as a requirement, it's left up to the individual sites in terms of the existing protocol. And I'd be interested in hearing Dr. Cote's comments on it as well, because you experience the other side of the slate where it affects how many patients you can see if indeed you take scopes out of use while they're being quarantined.
Right. So you have to have sufficient inventory for quarantining your endoscopes, which is it's a big cost burden, certainly for the facility. It's an initial investment. It's not a sustained investment, but nevertheless, it's substantial. And so I think, but on the other hand, I think that quarantining is really the only way to do this because of the perception and the complication that can come with trying to explain to patients after the fact. Let's say you've obtained your culture, but you continue to use the endoscope while the culture is in process. And in the event that you now have identified a high-risk organism, which we'll be discussing here shortly, now you're left with the dilemma. Do you contact the 2 or 3 patients, or maybe more, that have been exposed to that duodenoscope, or that if it's a linear echoendoscope or any scope that you're culturing, do you contact all those patients and say, well, we're really sorry to let you know, but FYI, you may have been colonized, exposed to, a sample that was obtained from this endoscope. We didn't know it when we used it, but now we've identified it after the fact. It's a tremendously difficult question, and I think I've heard a lot of gastroenterologists say, well, if the patients are asymptomatic, you don't really have to you don't have to necessarily notify them. But then it's a medical legal liability, and it's an extremely difficult and complicated conversation to have with your patients who are almost undoubtedly going to be asymptomatic. So I think that, again, as a part of your commitment to culturing, I really think that quarantining the scope while you wait for the results is really the only way to go. Again, it's not a requirement. As Michelle said, the FDA didn't specify this, but to me, I see no other way around it. I just think it's a cleaner program.
Mm-hmm. I think the other tricky thing that's good to talk about at this point, and I think you mentioned it earlier, like the FDA protocol also doesn't specify the frequency with which to do culture if you choose to do it. And I noticed that some of our responses coming in on the website, and I know some centers may do it infrequently and others do it very regularly. But I think it is optimal that every week there should be some, if you're going to do this, especially at the beginning, even if you do it for the first time and you're wanting to see kind of what's existing in your center, it would be good for a number of weeks to actually do some scopes every week for a period of time until you've actually got a sense of what the status is for the duodenoscopes that you've got within your site. And then after that, determine what the frequency will be. So again, the FDA protocol doesn't specify it, but the idea of trying to do some scopes every week, I think, is one that allows you to assess a wide range of the scopes that you've got and have some knowledge or some indication about the contamination rates in them.
Michelle, we had talked about drying during the last of these webinars, and I don't think we've specified when this culturing can occur relative to after the reprocessing has been completed, after the unit has been taken out of the the machine.
Yeah, and thanks for bringing that up, because that is an important one. If you're going to collect a sample from a duodenoscope, the two times, or the time points at which that could happen, one is when you have fully cleaned it, put it through the high-level disinfection in an AER, and you've taken it out of the AER. You could sample it at that time. That's immediately after high-level disinfection. The expectation is that there should be no organisms other than maybe the potential spore-forming organism or so in low levels. And that's a very valid time at which to take the culture, because it really is assessing how good your cleaning and disinfection process was. The other stage at which some people have taken cultures is after storage, maybe storage overnight or storage over the weekend. And what that will also give you some feedback on is whether or not there's any replication that is occurring because you've left moisture in the channels during storage. And so both of those times are legitimate stages at which to take culture. I think when you're starting out, it's not a bad idea to start your assessment right after the AER cycle is finished. But if you choose that you can't do it at that time for some reason because it's too difficult, or you're in the middle of doing things and it just doesn't work out, the other opportunity is to allow the scope to be stored overnight, and then you can still take a sample maybe before the endoscopy procedures begin on a few of the scopes that are going to be used that day. And if that fits better into your clinic cycle, then that's great. Those are the two times at which samples can be taken.
Great. So I think, Michelle, in the last couple of slides and through discussion with both panelists, we've gone over kind of a little bit of, you mentioned gram-negative, gram-positive organisms. You taught us what a CFU, a colony-forming unit, is. So I think it's time now to really dig down deep into the lab reports. And again, I think I mentioned this at the beginning. This is something that can really be confusing if a facility has just started with a sampling and culturing program and gets their lab reports back and then has to decide, how to interpret the lab reports and then what happens then. So this slide here is one of yours: high, moderate, low concern. What do these things mean?
Yes, and this is taken directly out of the FDA CDC ASM protocol definitions. High concern organisms are those that were most associated with disease. They're the ones that have been detected in the outbreaks that have been reported, or they've been associated with having been proven to be associated with contamination of the endoscope. And keep in mind, a lot of the times, the reason we're picking these out now as ones that are I guess, as opposed to endogenous infection, where the patient's own E. coli is causing an infection and it's a risk of having had a duodenoscope procedure and it wasn't from a contaminated scope, versus contamination from the endoscope. And the outbreaks that have happened, most of them have been associated with multi-drug resistant organisms that are in the endoscope, and the same organism was shown in a patient that either got colonized or infected with that exact same strain of organism. So in terms of high concern, gram-negative rods are at the very top of the list, and that includes Escherichia coli, Klebsiella pneumonia, any of the gut organisms that fall into the Enterobacteriaceae family. And other high concern organisms that were included in this list were Staph aureus, beta hemolytic streptococci like group A strep, Enterococcus species, and yeasts. And so it's a combination of ones that have been associated with disease and associated with the outbreaks. The gut-derived gram-negative rods are quite worrisome, because that would suggest that the isolates from a previous patient are now present and have been transmitted to the next patient. Now, moving down to the next row, the moderate concern, these organisms are less associated with disease and are commonly found in the oral cavity. There was a lot of discussion about, okay, high concern organism. I think most of us can agree that those are ones we just don't want to see, period, and you shouldn't see ever from a fully reprocessed endoscope. Moderate concern and low concern are a lot more difficult to deal with. And the middle group is the most controversial. So saprophytic Neisseria, Viridan streptococci from the oral cavity, and Moraxella species. Occasionally, they might be able to cause infection in humans, and certainly, been involved in, endocarditis and things like that. But the reality is they haven't really been associated with any of the outbreaks that were linked back to contaminated endoscopes. And the low concern organism are very seldom associated with disease. Micrococcus, coagulase negative staphylococci, obviously excluding Staph leibnizensis, bacillus and diphtheroids. And so the low concern organisms, again, mostly they're introduced accidentally at the time of sample collection, or the scope might have them because they were stored under, obviously under non-sterile conditions. But these are the categories of organisms. And I think the important thing is the focus on the high concern organisms, or where there's an exceedingly high number of organisms growing, which just shouldn't be. And this slide is also from the FDA CDC ASM guideline. And if you have greater than 100 CFU, it doesn't matter what organism it is, that requires action. You should never see, if you've taken a sample right out of a scope that's come out of an AER just after high-level disinfection and you see 100 CFU, that should never happen. Something is seriously wrong. And so it requires action regardless of what organism is there, high concern or low concern. If there's between 11 to 100 CFU for high concern, obviously that requires action because there should be 0 CFU of high concern organisms, but it's still verging on a very high number, and that has been defined as an alert category. The 1 to 10 CFU, again, for high concern organisms, that requires immediate action. And for low to moderate, there is no need to really take action. And obviously, if you get 0 CFU, you don't need to take any action. That's the ideal situation, is where you have nothing growing in the sample that you've done a culture on.
Okay, and moving on here, this is another one of your slides, Dr. Alpha. I think this does a really good job of kind of letting people know when you have to take an action. So maybe we'll start that conversation with this slide.
Okay, so the hard part about culture is it does take a number of days. You take a sample, you send it, let's say it goes to an external lab, it's going to take a day to get there. They set it up for culture, and what they're going to do if they see any growth, the first report that comes back to you will be something that will indicate that there is an organism growing, and your first information will be the gram stain result and how many colonies of that particular organism are growing on your filter on your blood agar plate or directly on your blood agar plate. And so the reality is, and this is a clinical microbiologist perspective, when you get that report and you see a gram-negative bacilli, 1 CFU or any number, it doesn't matter how many of them, even 1 CFU is actionable, it really means you need to kick into gear and go to investigating and figuring out what's happening, because you should never see gram-negative bacilli growing from an endoscope. And the second component where action is required is if your initial report shows you more than 100 CFUs growing, it doesn't matter what the gram stain is, that requires action as well. And we're going to get to what that action is in a few slides. But the other types of organisms that could be reported on a gram stain are ones like gram positive, and I should mention that picture at the top right there, which is a pink looking rod-shaped organisms, that's a gram negative bacilli. That's what they look like on gram stain. So gram negatives always look pinkish colored, gram positives always look purple or bluish colored. And so a gram-negative bacilli means it's going to be, something like a Pseudomonad or an E. coli, Klebsiella. Those are all gram-negative organisms, and they're the ones that are high concern and you need to act on. If we look at the next bottom part of the slide, if the CFU is less than 100 CFU, you really don't know what it could be if it's a gram-positive cocci, and you could see the image right beside there, those purple-looking little balls and clusters. That's gram-positive cocci. And if you look to the right of that, you'll see an image that shows you gram-negative cocci, little balls that look pinkish. Or if it's a gram-positive bacilli, like the picture at the bottom, that is an indication of organisms which may be high concern, or they could be no or low concern. So you pretty much have to wait to actually see what the identification is. So for example, a gram-positive cocci could be a Staph aureus, which is a high concern organism, or it could just as easily be a Staph epidermidis, which is not a high concern organism. And so, you know, in terms of what can you do when you get that first report back, this is an example of what you can act on and what you probably need to wait on because you don't know, well, what level of organism it is.
All right. So I think at this point, if everybody can kind of imagine, you've taken your sample from your scope, you've quarantined it, hopefully, waited a couple days, and you've gotten kind of your initial culture result back, which is this slide, and it will tell you basically, is there growth? Is there no growth? How much growth is there? It's usually some sort of CFU count. Maybe you get four CFU of a gram-positive cocci. So this next slide kind of walks us that one step forward into figuring out how to get that information that tells you exactly, or at least in some categorization of what organism you're dealing with. So Dr. Alpha, if you can kind of walk us through these different methods that are available for that.
Yeah, historically, a lot of the larger labs actually had biochemical assay methods, micro methods that relatively faster than the slower archaic methods that used to be used. So systems, automated systems like Vitek or Microscan or some of the other ones, you know, they're based on traditional biochemical assays, and they take usually a day or two to identify the microorganisms. So you put the organism into all these little trays, you put it in the machine, it incubates, it monitors to see, does it ferment glucose or not? And then within 24 to 48 hours, you will get an identification that will come out based on its database of different patterns of biochemical reactions. The latest system that's available, and many of the clinical diagnostic labs and private labs would have this, is what's called, on the second bullet there, MALDI-TOF. And these systems are wonderful because if you've got a colony growing on that agar plate, the traditional systems you require to set it up, incubate it, and then analyze the biochemical assays in 1 to 2 additional days. Whereas the MALDI-TOF, you can take a small portion of that colony, put it on a template which goes into the machine, and within about 5 minutes, it's going to give you an identification based on the protein profile of the organism. And for most of the organisms that are high concern organisms, they're classic clinical pathogens, gut organisms, MALDI-TOF can identify them very rapidly. So it's the preferred ID method if it's available. So when you contact your lab, it would be good to know how long it would take them to give you some results. And the third bullet there, the DNA sequencing methodology, can take many days to weeks in terms of getting the results back. And in my opinion, as a clinical microbiologist, I don't think it's necessary for routine endoscope culture methods for high concern gut organisms and for the pseudomonads or the gram negatives that might contaminate the AER system. Those most of the time can be easily identified by routine lab methods, and MALDI-TOF is very good. And the nice thing is you will get results back much quicker. So if you are going to be doing culture, one of the things you have to identify is do you have a microbiology lab on site, a clinical microbiology component, or are you going to be sending your samples to a private lab? Both of them are perfectly acceptable, but I think it's important to have a discussion with the laboratory that you select to make sure that their method for doing the culture complies with the FDA, CDC, ASM protocol, and that their speed with which they can give you results, preferably if they have a MALDI-TOF, that's a great way to do it. So they feel comfortable. They know you don't need DNA sequencing on these types of isolates. And the other thing I think that I'll just mention at this point is remember that if you do get a high concern gram-negative organism, normally on these types of non-patient samples, antibiotic susceptibility wouldn't routinely be done, nor does it need to be done. But if it's a gram-negative bacilli and it turns out to be a gut organism, it would be good to ask to have the antibiotic profile, sensitivity profile done on those isolates, because if it's a multi-drug resistant organism, the implications of that are a little bit different than if it's a regular run-of-the-mill gram-negative organism. And so that would be the only time where antibiotic susceptibility testing might be considered.
Great. So at this point, we got our bioburden, we got our CFU count, we've determined that we need to do some sort of microorganism identification to kind of further see beyond the gram stain what we're dealing with. We just talked about several methods that can be used to get that extra level of information. So if you wouldn't mind now, if you could kind of walk us through this table that encompasses just some of the high concern organisms that facilities might see, and kind of explain through this table.
And I love these tables because as a clinical microbiologist, I love all the bacterial names. Acinetobacter calcoaceticus, you know, it just rolls off the tongue. But I have taught many students in my years who the topic they hated worst was microbiology because of all the awful microbial names. So this table, I love it. So bear with me. You know, obviously, Acinetobacter calcoaceticus or Bowmanii certainly could come from, they are high concern organisms. And these organisms, there's outbreaks that have been associated with care environments where in ICUs or in wards, this is one of the few gram negatives that actually can survive quite well in the environment. And it also can be found in water sources. So it's one that lurks about for long periods of time in the environment and certainly is a concerning organism. Enterococcus faecalis and faecium obviously is gram-positive cocci. The healthcare environment certainly can be contaminated with them, and they're indicators of gastrointestinal tract microorganisms. And then Escherichia coli is the classic gastrointestinal organism, as well as Klebsiella pneumonia, Klebsiella oxytoca. And the presence of those organisms in an endoscope after full reprocessing is really concerning because it does suggest that you have had organisms from a prior patient that survived the entire process and they're still in that scope. And that shouldn't happen if it's been done properly. Organisms like Pseudomonas aeruginosa and Stutzeri, they're high concern organisms. They can be found in the environment, definitely. And Pseudomonas aeruginosa is amazing how well it can actually grow in water environments as well. And Staphylococcus staph aureus, as we mentioned, is a high concern organism, as well as Staph lugdunensis. They're gram-positive cocci, and they're found on the skin and mucous membranes. And as you start seeing, these ones are all pretty much high concern organisms, but what you might see also are some of the low concern ones, like you might see Staph epidermidis or some of the other staphylococci that show up. And if you see Staph aureus or Staph epidermidis, some of these in high numbers, the low concern ones, you've got to question whether the handling of your fully reprocessed scope was done improperly or whether there was introduction of skin organisms into the sample during the sample collection. Staph aureus, on the other hand, one would hope wouldn't be there in high levels on the hands and shouldn't get introduced. But these are examples of high concern organism that certainly can be seen on culture of endoscopes.
All right. So that was everybody's review of their last microbiology course. I hope we're still hanging in there. So that was great. So now, you know, that was exactly what we wanted to do, and hopefully for the attendees, we gave you at least an idea or a general idea of really what has to happen when you get a lab report. What do you need to look for? What does it mean? So now we're going to move on to actionable items. So, you know, keeping in mind everything we just talked about, what really happens or should happen if a facility does get a lab report from an endoscope culture that shows one of those actionable levels, so a high concern organism or any organism greater than 100 CFUs. What action should be taken, and then who should be notified. So let's start, Dr. Cote, if you could give us your perspective. If you get one of these high concern actionable results, who needs to be notified?
I'm glad you didn't give me a quiz on microbiology.
That's coming next.
Yeah. Well, I mean, so again, when you're embarking upon a program like this, you do want to, your infection control group should be a part of it in some capacity or another. They should obviously be at least aware of the fact that you are doing it. And so they immediately need to be notified, number one, to help interpret the significance of the finding, although your endoscopy nurse managers and endoscopy directors need to know that this is a significant result as well. You should not rely on your microbiologist to tell you You'll want to call, I think, risk management just to make sure that they're aware of the fact that you've now identified that there may be a breach in your reprocessing system. There may not be, but just to make them aware of the fact that you're now going to be doing a root cause analysis, which is the next thing you'd want to do, which is to look at that endoscope and evaluate the process that it went through prior to the culture taking place. And we'll discuss, I think, the concept of reprocessing, culturing, and what to do if you have sometimes it can be a damaged piece of equipment that can lead to this issue as well. So those types of things all need to be evaluated. But obviously, at this point, this is the objective of a culturing program, right? Is to potentially identify a hole in your process, a gap in your process that led to this culture. And so it may be a personnel adjustment, retraining. It may be something to do with handling of the piece of equipment, and it may be that the piece of equipment itself needs to be assessed or evaluated or / repaired.
Do you feel like, Dr. Cote, there's a need for a root cause analysis or some sort of error analysis to occur every time something like this happens?
I think when you have a high concern organism, I think you do want to look at, it doesn't have to go back to the entire, to your entire endoscopy unit necessarily, but that particular scope, I think you do want to go back and look at exactly what happened prior to the culture being obtained.
Okay. So next, we're going to look at some of the specific actions that are, can be taken when you get an action or an alert level result from an endoscope sample. So Dr. Alpha, I'll ask you to kind of walk us through these.
Okay, so if you get a high concern organism that requires action, as an example, I've kind of highlighted some of the key things. We talked earlier about whether or not duodenoscopes should be quarantined, and we hope that anybody doing culture is able to, make sure that they do quarantine their scope. But if they haven't, absolutely that duodenoscope needs to be removed from clinical use until the investigation or the assessment has been completed. There's a number of bullet items there about conducting the risk safety management response, including potential patient notification, processing practices, retrained staff, sampling and culture procedures, etc. And I think it's important to recognize that it depends, and depending on the organism that you isolate. So for instance, if you had, let's say you had 50 colonies of a Pseudomonas aeruginosa that grew on your plate, that really shouldn't happen. And obviously you'd remove the scope from clinical use, but focus on the potential origin for where that organism may have come from. And Pseudomonads are notoriously water oriented. And therefore, one of the first steps you should do is go through looking at how the sink in the reprocessing area is being used. Is it being decontaminated after each of its uses? Is your AER, is the submicron membrane filter broken, and that's why you've now contaminated it with waterborne Pseudomonas, and it's showing up in the final rinse water of the AER. So a practical approach based on where that microorganism might have come from, I think, is important. But the second to last bullet is obviously if the scope has been identified as being contaminated, it needs to be completely reprocessed, and then it needs to be resampled. And the bottom bullet, repeat sampling and only return the duodenoscope to use if the culture results are acceptable and if reprocessing errors have been corrected as identified by the root cause analysis that you have done. So that would be, I think those are the key things about the sequence of action. And obviously, it's a big undertaking to have to actually do this. And so it really is important that this has all been thought of and that a game plan is in place before you start doing culture. You need to kind of have some pieces in a row to make sure you need to know what you can do. And it's kind of, I have this, sorry, excuse me, microbiologist again, right? Microbiology culture is like picking your nose in public. You better be prepared to know what to do if you find something. So boogers beware and culture results beware.
That is great.
That's amazing. All right. So can you explain, I mean, at a high level, really, again, I get confused by this, the difference between action and alert, and do you need to do things differently for those two categories?
Yes, let's just take the alert to begin with. The only time that happens is really when you've got higher than what would be expected levels of low to moderate concern organisms. So it's not a high concern organism, it's low to moderate, but the level is below 100. It's between 11 and 100. And that alert was put in because honestly, if you think about it, high level disinfection is supposed to eradicate all living forms of organisms except for high levels of spores or spore forming organisms. And to be honest with you, that to me, if you get that growing immediately after you've taken a scope out of an AER, you have a problem. Or if you get it growing after it's been in storage, that just should not be the case. And therefore, the alert is really review the reprocessing practices and retrain the staff. It's at a slightly lower level, if you will, than action. And review the sampling and culture protocols and do some audits to check. Staff will, there's often a written protocol, and then there's what really happens in real life. And sometimes the two are totally different. So I think the idea of in an alert, that's warning you that you're edging to a point that you don't want to be at, and that you really should go over the practices and make sure your staff are doing what they need to do, make sure they're given enough time to do what they need to do. And so it's a slightly lower acuity in terms of the response than it is if it's an action. And then I'll go on to the bottom part here, because this bottom part was put in if you have repeat positive cultures. In other words, a scope is repeatedly growing a high concern organism, even if it's not the same high concern organism. If it grows E. coli this week and you reprocess it and it is negative, and then the next week you retest it again and it is growing a Klebsiella, another gut organism. If it's not alleviated immediately by the reprocessing, there really is something wrong, and potentially it could be something wrong with the scope. And so that's why I think it's important that the scope is returned to the manufacturer. If you get consecutive positive results that show there's high concern organism there, it really should be sent to the manufacturer for assessment and revision or remediation as required. And the other thing is, obviously, if you've got repeated positive cultures, it might indicate that you're having some kind of subliminal low-level outbreak that's happening, and you need to make a decision about whether or not that needs more expanded follow-up in terms of your notifying the people that Dr. Cote mentioned, and also making a decision about whether or not you're worried about this organism, especially if it's a multi-drug resistant one. What's going on with that. So these are how will I put it? The bottom one is the worst case, where you have a scope that's repeatedly growing, high concern organisms. And as soon as you get two of those back-to-back ones, you need to send that scope back to the manufacturer. And the alert is just a lower level of checking, just to make sure that everything is being done correctly in the reprocessing.
All right, so kind of wrapping it up here, we're coming close to 8 o'clock. So I think Dr. Alpha, Dr. Cote, in 1 or 2 sentences, how do you feel that information obtained through an endoscope sampling and culturing program really impacts patient care? And we'll start with Dr. Cote.
Well, I think it will hopefully reinforce the fact that it will quantify the fact that you're doing a good job with your endoscope reprocessing.
Hey, Dr. Alpha.
I would reiterate that as well. And I think that it's a positive thing, and staff shouldn't see it as a negative. It's a positive way to show that what they are doing is consistently being done right, correctly, and that their patients are being well protected, that the reprocessing is being done in a stellar way.
Great. And one more question, and this one's for you, Dr. Cote. So in our previous webinars, we talked about how the risk of patient infection from inadequate reprocessing is low. And given this, would or should a physician be concerned about utilizing a conventional or reprocessable duodenoscope on any patient or even a specific patient population?
No. Again, the principal goal, these are life-saving procedures, or they're replacing much more morbid alternatives to deal with the problems that we're addressing. And so there is no scenario in which I can imagine not using a reusable endoscope, with the exception, I suppose, of prion disease, which I don't want to bring that up with Michelle. We will need another hour to get into that. But I mean, basically, no.
Right. And Dr. Alpha, any last words before I kind of wrap this up?
No, not really, other than to say I do think it warrants facilities actually doing some level of culture to have an understanding of how well they're doing in their reprocessing, and that the FDA CDC ASM protocol is just an absolute wonderful way to do that. And then how you roll that out or deal with it afterwards, you know, at least you've got some information from your site.
Great. All right, so we are at 7:59, so I'm going to go through this super quick to be respectful of everybody's time. I know I have to go still feed myself and my husband, so I got to get out of here. But really, just for attendees, Olympus does have several resources available to you on this topic and other topics. One is there's a new white paper written by myself on tips, tricks, and insights for implementation and management of an endoscope sampling and culturing program. Pretty long paper. I apologize. I think it's 12, 13 pages, but it's really meant to be a comprehensive kind of walkthrough of things that you want to take into consideration to really have a quality sampling and culturing program, should you choose to have one in the first place. Also, recorded versions of all 3 of these webinars in the series will be available in the next few weeks, I would say, on the Olympus America webpage. So be on the lookout for that if you want to review, rewatch, or share them with your colleagues. Other Olympus resources available to you. We have an online resource library with things like wall charts, on-track forms, checklists. We are still doing instructor-led programs, not large ones right now, but if you are an Olympus customer with a service contract, your endoscopy support specialists are available to you to come into your facility and help you with your reprocessing and repair reduction needs. We have off-site programs. We have a new learning module, quiz module that is totally online for duodenoscope reprocessing. Olympus Professional Education has also started to put their educational courses online in an on-demand format because of COVID. Check that out. A lot of them are for CE credits if you're in need of those. And also, of course, CDC does have some additional free information that you can use should you want it on performance and quality improvement in your facility. And then again, this duodenoscope sampling and culturing protocol from the FDA, CDC, and ASM is available for free on the FDA website. And I will give you a quick hint to find it. Literally, if you go to Google and type in FDA duodenoscope sampling, it is the second hit. You can tell I do it like every day. So we do have one question, and I know we're a little over time, but I did want to make sure we address this. Let me pull it up here. And Dr. Alpha and Dr. Cote, actually, both of you, if you could weigh in on this, are there any recommendations that exist for sampling and culturing scopes other than duodenoscopes, and do you think this offers any clinical value?
Well, I'll start off because the FDA CDC ASM protocol actually does have an appendix, and in it they identify the sample volumes and how you would approach culturing, colonoscopes, gastroscopes, bronchoscopes. So it's not intended to give you a step-by-step process, but what it does do is identify, because obviously there's different channel volumes, and so you need to know that there is an appendix that helps with that. I'm trying to think, what was the last part that you asked about? Whether there's value?
Is there value? Yeah.
I'll say absolutely, because it's not just duodenoscopes that get contaminated. If you look in the literature, you'll find published problems with, gastroscopes, colonoscopes, bronchoscopes. They've all had problems with scope contamination that's been transmitted to patients or caused false positive culture results for bronchoscopes in particular. So, it's not just duodenoscopes that have problems with contamination. And I think we focus on that because they're very complex, the lever devices, and I think most prone to having this problem.
Dr. Cote, do you have anything to add to that?
No, I don't think so. Just it is important to remember that we kept talking about duodenoscopes, but really this is all encompassing for all flexible endoscopy.
Okay. All right. And with that, we've reached the end. Thank you for hanging in there a little overtime for attendees that are still on the line. You know, on behalf of Olympus, I really hope that this webinar did provide valuable information and insights, not only into sampling and culturing, but with our previous webinars on topics related to patient safety and quality measures in endoscope reprocessing. Big thank you to our panelists for sticking in there with us over the last 3 webinars. Dr. Michelle Alpha, Dr. Gregory Cote, thank you for sharing your expertise with us tonight and throughout the entire series. To the attendees, we do ask if you have an extra few minutes, please remain here in the webinar. You will be automatically redirected to a quick survey, and it would be very helpful if you could take the time to complete it, because the information we gather from surveys like this helps us to continue to develop and present educational content that we hope is useful to you in your practice. So again, thank you everybody for your time and attention. And with that, I say have a wonderful evening.
Bye, guys.
Thanks, everybody.
Bye-bye.
Take care.
Yeah.